Dr. Ho and I put together this educational video for physicians and healthcare professionals on MR-guided breast biopsy. The general principles about MR-guided breast biopsy illustrated in this video apply to any equipment commercially available. The equipment shown in the video is what we use at our academic institution and is listed here. We have divided the topic in 5 sections for easy reference. The first section, General Concepts, is a general overview that can be of interest to radiologists and physicians referring the patient for the procedure. The remaining 4 sections are for radiologists. The basic biopsy technique is an overview of the entire procedure, and the following 3 sections have technical tips and tricks for radiologists that perform the procedure. The duration of each section is shown here, and the links for each section are listed in the YouTube description of the video. This video has Section B, Basic Biopsy Technique. This video may be of interest to radiologists new to this procedure, radiology residents and fellows in training, as well as MRI technologists performing this procedure. This is an overview of the entire procedure from the preliminary steps to the final radiologic pathologic correlation. This presentation is for radiologists performing the procedure or radiologists who want to be familiar with the procedure or radiologists in training. The equipment shown in this video includes in vivo Sentinel breast coil, Aegis computer-aided software for breast MRI, Bard and Core Inspire biopsy device, and compatible tissue markers. A procedure is successful when it's well planned ahead of time. Planning begins at scheduling. This is the time when we give the patient preliminary information about the biopsy to prepare for the procedure. It's also when we review her medications and drug allergies and become aware of any concerns or questions the patient may have. It is also when the diagnostic breast MRI is reviewed by the radiologist scheduled to perform the procedure to ensure that the lesion has been fully worked up and the biopsy is indicated and necessary. The day of the biopsy is when the radiologist reviews the diagnostic breast MRI again and instructs the technologist about patient positioning and lesion approach. When meeting the patient, it's important to review her medications, medical and surgical history, allergies to medications, and answer any questions or concerns she may have. It is also very important to explain to the patient the procedure well, including the possibility of canceling the biopsy if the lesion is no longer seen. Before performing the biopsy, we do the timeout, obtain the informed consent, and verify that the equipment is ready. The equipment utilized for the procedure includes a bilateral breast coil to image the breast, a grid system with compression plate, and Fiducial to immobilize the breast and calculate lesion coordinates, the usual tray with prepping material, local anesthetic, a sterile Sharpie, an MR-compatible scalpel, and gauzes, an introducer or biopsy kit to insert the biopsy device within the breast, the biopsy device to obtain the sample, and a tissue marker or clip to mark the biopsy site. Patient and breast positioning should be planned before placing the patient on the table. The goal is to achieve optimal access to the target lesion while the patient is as comfortable as possible throughout the procedure. The padding covering the coil shown here may need to be modified, either increased on one or both sides or decreased or removed, depending on patient's habitus and lesion location. The breast may need to be deep or shallow, or flat or tilted in the coil, depending on the lesion location and approach. The arms may be placed above the patient's head or a longer side, again depending on patient's comfort and lesion location. Depending on the equipment, the patient will be placed in the scanner head or feet first. Most MR-guided breast biopsies are performed with a grid system as opposed to a pillar post. These images show a breast phantom immobilized within a plate and a grid. A grid shown on the right is composed of multiple squared openings outlined by rows and columns evenly spaced. The grid size and the number of rows and columns vary with each coil system. Two concepts are important for breast positioning within a grid: to place the grid to cover the area of interest where the lesion is, and to immobilize the breast, avoiding tight compression that may impair blood inflow. After positioning the breast within the grid, the next step is to place a fiducial marker to facilitate lesion location. Every system uses at least one fiducial that is called fixed fiducial because its position is fixed within the grid. This fiducial is used as a reference to calculate the lesion X and Y coordinates. In our system, the fixed fiducial is placed in the center of the grid at the block named C4. Additional fiducials may be placed in several systems to improve accuracy in X and Y calculation. Once the fiducials are in place, we're ready to place the patient in the scanner and start imaging. Unilateral imaging is preferred unless it's a bilateral biopsy. The main series is an axial fat-suppressed T1 weighted sequence, the same used for the multidynamic series of the diagnostic protocol. Parameters and magnet used for imaging during an MR-guided biopsy should be the same used for the diagnostic breast MR and in compliance with the requirements of the ACR accreditation for breast MRI. This is to achieve the same spatial and temporal resolution and facilitate comparison of the diagnostic and biopsy breast MRI. Following a localizer sequence, imaging is performed prior to the biopsy, before and after administration of contrast. One or two post-contrast series may be obtained. Subtraction may be applied to the pre- and post-contrast series. During biopsy, two series are usually obtained. The first series is obtained after placement of the obturator, and the second series is obtained after the biopsy. While the radiologist is calculating the lesion coordinates and planning the procedure based on the post-contrast series, the technologist may perform an optional sequence, an isotropic high-resolution series, helpful for multiplanar evaluation. The first series following the localizer sequence is the pre-contrast fat-suppressed T1 weighted axial sequence. This is performed for three reasons: ensure that the lesion to be targeted is included in the area covered by the grid, verify adequate fat saturation, and use this series as a mask for subtraction. The second series obtained after the localizer is the post-contrast series. This is performed for two main reasons: confirm that the target is present and amenable to biopsy, and plan the biopsy, meaning calculate lesion coordinates either with manual technique or with computer-aided assistance, choose the needle type and sample size, review the parameters, and make sure that sampling is clear of skin or muscle or contralateral side of the breast. Once it's confirmed that the biopsy will be performed, we need to set up the equipment. At our institution, the radiologist sets up the biopsy kit and the technologist the biopsy device. Various biopsy kits are made by different manufacturers. At our institution, we use the kit compatible with the BARD and Core biopsy device. Most biopsy kits consist of a coaxial system and a needle guide. The coaxial system allows access to the breast, and the needle guide or grid block holds the coaxial system in place. The coaxial system has an outer component called plastic cannula or introducer and two inner components that are inserted at different times and are the stylet and the obturator. The outer component of the coaxial system, the plastic cannula or introducer, stays in place throughout the entire procedure and allows placing the biopsy device and the clip at the targeted lesion. This introducer has numeric marks indicating the distance from the tip and a mobile depth stop to facilitate placement at the desired depth and lock to the needle guide. The inner component of the kit includes two separate tools. The stiff metallic stylet is used as a support while inserting the plastic introducer within the breast, and the obturator that is used to hold the plastic introducer in place during imaging within the magnet. The needle guide, also called the grid block, is the connecting piece between the coaxial system and the grid, and has the function to keep the introducer and biopsy device in the correct location. Some biopsies, for instance those performed for superficial targets, may need to be performed without a needle guide. However, usually the needle guide is used to make sure that the system stays in place throughout the entire procedure. This is how we assemble the introducer kit prior to biopsy. First, the stylet is introduced inside the plastic cannula. Next, the introducer depth stop is mobilized by sliding it along the length of the introducer so it can be easily moved to the desired depth later. Then the needle guide is placed over the assembled plastic introducer and stylet. The kit is now ready to be inserted within the breast. Notice how the depth stop fits into the needle guide and locks to it. Also, notice that the stylet protrudes a little bit greater than 2 centimeters beyond the plastic introducer to create a path for the biopsy device. Notice also the step at the junction of the plastic introducer and stylet. This can be a point of resistance while inserting the system through the skin, in particular if the dermatotomy is small. So it is useful to keep the needle holder close to the proximal end of the introducer to visualize the coaxial system in its entirety while it's advanced through the skin incision. This is a phantom to show the preliminary preparation of the biopsy site. Once the correct grid opening is identified, the skin is cleaned with 3 iodine swabs. Then lidocaine buffered with sodium bicarbonate is injected to anesthetize the skin at the entry site and the deep tissue along the needle tract. Additional lidocaine with epinephrine is administered in the deep tissues to decrease bleeding complications. We advise to perform a dermatotomy to facilitate the insertion of the stylet. A vertical dermatotomy is performed by introducing the full blade to the green plastic mark in the skin overlying the lesion that we just anesthetized. We're now ready to place the introducer set through the dermatotomy. Notice how the needle guide is kept close to the stylet to see the skin entry site well. We're now going to show you the steps to place the introducer kit at the desired location, from the first step of inserting and advancing the introducer kit inside the breast to the last step of locking the introducer depth stop to the needle guide. It is easier to advance the introducer kit inside the breast with a gentle twisting motion. Once the plastic introducer has entered the skin and there is no skin indentation or pulling, the needle guide can be inserted and locked to the grid. At this point, the introducer can be advanced to the desired depth, and the depth stop can be secured to the needle guide. Once the plastic introducer is inserted at the right depth, the stylet is removed and the plastic obturator is inserted within the plastic cannula. The patient is now ready for imaging. Imaging is now performed to verify the location of the obturator and therefore the plastic introducer in relationship to the lesion, as the lesion or tissue might have shifted while injecting the local anesthetic or inserting the stylet or the obturator. The optimal position of the bright obturator is near the lesion, as shown in this case. In some cases, an adjustment may be needed if the obturator is too deep or shallow. If the introducer is too deep, it may be simply pulled back. If it is too shallow, however, the stylet needs to be reinserted to advance the introducer farther. If the obturator tip ends close to the lesion, sampling should be successful. This is because the obturator tip corresponds to the center of the aperture of the biopsy device. So when the obturator is removed and replaced with the biopsy device, sampling occurs in the area of the lesion. Once the position of the obturator and introducer is verified, we are ready to proceed with the biopsy. The obturator is removed and the biopsy device is inserted. We use a single insertion multidirectional 10-gauge vacuum-assisted biopsy device, and we usually take about 12 samples. After the biopsy, the cavity is usually lavaged and aspirated to minimize post-biopsy changes and facilitate confirmation of successful sampling on a post-biopsy imaging. Post-biopsy imaging is performed after the biopsy device is removed and replaced with the obturator. This imaging is important to evaluate the interval change of the targeted lesion, the location of the biopsy cavity, and the presence of a possible hematoma. If the lesion is smaller or no longer seen, the biopsy is most likely successful. If the lesion persists or is unchanged, more sampling is needed. If the lesion is no longer seen because of timing, the location of the biopsy cavity should help to confirm successful sampling. If the cavity is not centered in the expected location of the lesion, additional sampling is needed. If a hematoma has developed, additional aspiration or immediate clip placement and prompt conclusion of the biopsy should follow. Tissue markers are utilized to identify the biopsy site for future reference. Multiple types of tissue markers are available. The tissue marker that we utilize comes in a metallic applicator with a sharp tip, an adapter, and a locking mechanism. To deploy the clip, the obturator is removed and the tissue marker adapter is connected to the plastic introducer. Then the metallic clip applicator is completely inserted and the locking mechanism is twisted to unlock the clip. The clip is then pushed and deployed within the biopsy cavity and the rigid applicator is removed. At the radiologist's discretion, the biopsy may be concluded or a post-clip sequence may be obtained. If imaging is desired after clip placement, the obturator is inserted again inside the plastic introducer. This time, the obturator is only partially inserted to avoid displacement of the clip. Then the patient is re-imaged. If imaging is performed, we advise a T1 non-fat suppressed series to better visualize the clip artifact, as the clip is often difficult to distinguish from the biopsy cavity. Immediately after the biopsy, the patient is transferred to a stretcher and manual compression is applied over the biopsy site to achieve hemostasis. After the patient has recovered and a dressing is applied over the biopsy site, the patient is escorted to the mammo suite for a post-biopsy mammogram. After the procedure, it is important for the radiologist to review all the MRI biopsy sequences and the post-biopsy mammogram to verify whether the lesion was sampled adequately and the clip was placed correctly. Proper documentation should be stated in the report. As for any breast biopsy, the radiologist needs to correlate the imaging and pathology findings to assess for concordance. Usually, benign pathology results are followed with MRI, typically at 6 months. Inadequate or discordant results require a repeat MR biopsy or an excisional biopsy. High-risk lesions are referred for surgical consultation and malignant lesions for treatment. In summary, breast MR biopsy is a complex procedure that requires multiple steps. Preliminary steps involve planning at the time of scheduling and the day of the procedure to prepare the patient and the team for the biopsy. The success of the procedure is dependent on patient positioning and controlled immobilization of the breast, imaging, and vacuum-assisted biopsy device. Lastly, after the biopsy, it's very important to review the MR imaging entirely, correlate mammogram and MRI, and perform a careful radiologic pathologic correlation. This concludes the basic biopsy technique section.